Hello, welcome everyone to today's webinar, The Future of On-Call Scheduling and Communications, Aligning IT Systems to Improve the Provider Experience. On behalf of Becker's Healthcare, thank you for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. We're going to begin today's webinar with a presentation, and we'll have time at the end of the hour for a quick Q&A session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Number two, today's session is being recorded and it's going to be available after the event. You can use the same link you used to log into today's webinar to access the recording, so make sure you save those emails. Number three, if at any time you don't see your slides moving or you're having trouble with the audio, first try refreshing your browser, and you can also submit any technical questions into the Q&A box, and we will help you. With that, I am pleased to welcome today's speaker, Dr. Patrick Guffey. Dr. Guffey is an associate professor of anesthesiology at the University of Colorado and practices pediatric and fetal anesthesia. He serves as the Chief Medical Information Officer at Children's Hospital Colorado and Performance Improvement and Informatics Officer at the Department of Anesthesiology, University of Colorado. Board certified in clinical informatics, Dr. Guffey partners with Epic, Qgenda, Codonix, and Omnicell to improve clinical care and decrease medical errors. His research interests center on application of the electronic health record and clinical informatics to improve quality, safety, and outcomes. Dr. Guffey is particularly interested in interoperability and using informatics to drive highly reliable, efficient patient care. Dr. Guffey, thank you for being here today. I'll turn the floor over to you.
Thank you so much for having us from the Becker's Hospital Review team, and also for Qgenda for hosting today. Today we're going to talk about our journey across the communication spectrum, moving from pagers to modern electronic devices for communication and how that impacted us, background, and from there. I have no conflicts of interest to disclose. I do serve as a officer for two boards of directors in an uncompensated fashion. And I'll just remind everybody today that the views and opinions I express in those presentations are mine solely and alone and do not necessarily represent my employers. A little bit about Children's Hospital Colorado as we go through some of the examples and how this impacts us. Top 10 children's hospital in the western part of the country here in Denver, Colorado. And we have about an 850-mile radius to the next closest top children's hospital. So communication is very important to us. And we serve the 7-state region as shown here. And have also been very active in the informatics space with HIMSS. And as you can see, have really worked hard to stay as innovative as possible. So our agenda for today, I want to talk a little bit about the drivers for change that caused us to embark on this journey, a little bit on communication theory and what we call our communication matrix, our solution that we rolled out to solve these issues, a little bit on topics of resiliency and how we reinforced our strategies, and then really at the end, reviewing from what we've learned through this process, we view as an ideal communication strategy going forward. So let's start with a little bit of safety in communications and why this is so important to us. So the Joint Commission found that 30% of malpractice claims had a major communication failure component, and they also found that 70% of Sentinel events had a communication failure as part of them. So communication is really a key part of how we function in a healthcare environment. And as you can imagine, with healthcare being one of the most complex industries in the world, our ability to work with each other, communicate with each other, and get key information moved between our care teams and our providers is critical to safe patient care. So we knew it was time for a change, one, because we know that communication again, is a key factor in patient safety events. And anecdotally, from my work as a reviewer as part of the American Society of Anesthesiologists Quality Institute, reviewing that data, we know that communication shows up in many patient safety events. And pagers are really an old technology. I put 1990s up here, but they date back into the 80s and even before. And part of the issue is they're a separate piece of technology that we have to carry, and they're not integrated in how we work. So thinking of things like the EHR, how is a pager really connected into that environment when so much of our clinical work now is in the EHR? They also are separate and don't have a link to the patient. So if I put a medical record number into a pager, I'm doing that typically manually. And if I transcribe the wrong medical record number, that could have serious downstream implications versus should that be brought in automatically. And finally, my favorite, if cell phones were invented before pagers, pagers wouldn't exist. So this is really a technology that has outlived its life. The other problems we notice with pagers are is that most of them are not HIPAA compliant. They send clear text over a radio band. And another thing we've noticed is that some providers are forwarding pagers to their cell phones as clear text SMS messages. So that sets up a serious issue. Is one of the HIPAA provisions that is critical here is that it's encrypted. You can manage it, potentially delete it, know where it goes. And sending those messages over SMS defeats those limitations that are critical to that. So at that point, we really had two options here. We could encrypt the pagers, and there are ways to do that, or we could put an app on someone's phone. And given how many apps that people already have on their phones, we're not going to go back to the future and install another app. We decided that if we were going to install another app, we should use one of the existing applications that we're already using in our workflow. The other thing that's wrong with pagers, and I think this is a little entertaining, we were about 7 years late to the party in throwing out our pagers and moving forward. This is from one of the medical kind of entertainment sites. It's Gomer Blog for those that are familiar. And National Toss Your Pager in the Trash Day was October 16th, 2015. And while this is obviously a parody, you can get a feel for how physicians feel about their pagers by looking at some of it here. I like the "Oh my God" button that activates a self-destruct sequence, or speed dial mom for support, and that pagers don't even need batteries. They're just powered by misery. So really, pagers have a long history in the healthcare profession, but many of us are definitely ready to move on. And I think we were maybe a little bit late to that party. And on a more serious note, what's really the definition of burnout that we're facing from a communication standpoint? What you're seeing on the screen here are 10 different communication methods that a provider needs to manage. And we'll just go through them briefly, but in many hospitals, this is what our providers are facing. They can get text messages on their personal cell, the aforementioned pagers. There might be different applications for messages coming in externally versus internally. There's EHR messaging platforms now in many of the largest EHR vendors. We might use a phone call to connect via a personal cell, or voicemails left on personal cells. There's also work phones and hospital phones that can do the same thing, where you can get phone calls and voicemails left and have to check those. There's what's called the EHR in-basket, which is like an email program effectively built into many EHRs. And then there's work email on top of that, and sometimes even personal email gets involved. And really, that's what that leads to, is upset clinicians trying to manage all these different communication streams while providing excellent, safe patient care. And it's a challenge. This is a picture of me about 15 years ago when I was an anesthesia resident. And I put it up here because you can notice the sheer amount of hardware that the three of us are wearing on our belts there. Radio pagers, standard pagers, trauma pagers. All of us were carrying at least 4 devices on call at this trauma hospital where I trained. And those are my fellow residents that were on overnight. So really what this project endeavored to do is we eliminated essentially 3 of these: text messaging via personal cell, pagers, and moving away from other clinical messaging apps in favor of EHR-based messaging. And I'll get to why that's so critical, but our goal is to work our way completely through this list and go from 10 to 3. We're at 7, but the ones that we want to be left with when we're done is EHR messaging, the EHR in-basket, and obviously phone calls for urgent issues to a work phone, not to a personal phone. So that's our goal as we get there. Now, a little bit about communication and where we are. There's 2 types of communication out there. There's synchronous and asynchronous communication. And I want to talk a little bit about asynchronous communication first. This is texting, messaging, pagers, email, and letters. And what I mean by asynchronous is you send a message, and then you wait for a period of time, and then you get a response. It's not a real-time conversation. So the pros to this is it's less interruptive, right? I can put my device on silent and I can check it when it's convenient for me. And on the sender's side, they can be fairly spontaneous because I'm not, setting up a time to have a synchronous communication and interrupting them. Now, the cons to this are it's open to interpretation because you don't have those social cues that we have that are so critical in getting information across. I can't see from a message if you're really concerned about a patient or if you just need some help with what's a relatively minor issue. So that's a very interesting way to think about it. Now, society is moving rapidly towards asynchronous communication. You can think in our personal lives now about all the different messaging apps we use. But recently in the last year, 2 major tech companies have used asynchronous methods to terminate their employees or lay them off. So it's not just the running joke about breaking up with somebody over text message anymore. Even employers are getting into this and using these asynchronous methods to deliver life-changing news. And that's definitely a shift in our society. So we need to take asynchronous methods really seriously and look at the impact that they have in healthcare, because this isn't going away. I'll occasionally run into providers that would just prefer phone calls, but that's not the way our society is headed, and we have to embrace and manage this technology in a way that's optimal for patient care. Synchronous communication is that in-person or telephone, telehealth over camera communication. It's interruptive, immediate, and it's less prone to interpretation issues because you have those societal cues. You can see if somebody's interacting or listening to you. The downsides to this is it's disruptive and it's inconvenient. So if I'm seeing a patient or I'm in the operating room focused on something, the other person can't see what I'm doing when they place that phone call. So they're interrupting me, and that has safety implications. So in an ideal world, we're interrupting when it's important, and we're using asynchronous methods when it can wait, and that allows the receiver of the information to stay focused on the task that is at hand, but then also escalate if they need to. Now, when we put this all together, the theory that's so critical is what's called closed loop communication. So communication's not effective unless we go through this loop. The sender initiates the message, the receiver accepts the message, provides feedback. This is what you said, this is what I heard, and we verify that that message was received and not just floating out in the ether. Now that's a lot easier with synchronous communication because you can have that back and forth in real time. You said cefazolin, I heard Kefzol, which antibiotic is it? We said discharge today, no, I thought I heard tomorrow. Is this patient going to the OR? Which patient's going to the OR, things of that nature. You can solve those really quick in a face-to-face conversation. That's a lot harder in an asynchronous method. So when it's asynchronous, we really need to make sure that we close that loop in how we do that. Now, part of what we talked about before was what communication method is the right one to use at the right time. And this really hasn't been mapped out before in the healthcare industry. But as we move to asynchronous methods, it's critical that we lay out a structure as to what is the right method to use when. So this is our communication matrix that we designed. We spent a lot of time working with our nursing informatics colleagues and our CNIO, Emily Reyes, to be able to do this. And you can see across the top is the mode of communication, and down the side is the appropriate method of communication. So across the top, we have an FYI, routine matters, important, urgent, which really replaces a lot of what pagers did, and critical. And down the side, you can see things like verbal, secure chat, which is our EHR-based solution. Tiger Connect is an external provider, in-basket messages, clinical correspondence, communication orders, and things like that. So what you can see here, as we go across and things become more urgent, we're limiting the methods that are appropriate to use. So if it's important, we should really be using a text message type platform or verbal, so our secure chat or verbal, and we're not using things like sticky notes or in-basket messages, which are again that email. As we get to urgent, which we defined as you need a response within 30 minutes, really only the secure chat method or verbal communication is appropriate at that time. And then for critical, meaning an immediate action is required, verbal is the only solution that we think is appropriate. So you should call that person or go to the bedside. And across the bottom, we're moving from asynchronous methods towards synchronous methods. So critical matters should be discussed with a synchronous method because time is of the essence. Less critical matters, asynchronous methods become more appropriate as you're not interrupting that individual. We codified this into policy, and that was really critical to do this. And you can see some of the key elements of our policy here, saying what critical priority messages are used for, FYIs, group chats are discouraged, scheduling questions should not be communicated via chat because it's interruptive and should be done in other ways. Secure chat users are responsible for setting our appropriate settings. And I think this is probably one of the most important ones I wanted to highlight. The sender of the message is responsible for verifying the message was received. And with tools, we can see when the receiver has read the message. And if we don't get a response, then we need to escalate it as the sender and not say to the receiver, why did you not take care of this? The receiver is responsible for taking action within appropriate time. But that is a highlight. That highlights that closed loop communication theory that if the receiver doesn't close the loop, then the message was not received. And the patient deserves us going the extra mile to make sure that the message is received by the right person to get the right care. So one of the other problems we face transitioning a little bit is in our organization, who really was on call? We had some issues with call schedule accuracy because largely it was a manual process. There was actually a book that had all the call schedules, and I'd imagine at many sites this is something that, that you've seen in your organizations. And anything on paper is not dynamically updated. So if somebody gets sick, trades with their partner, gets the opportunity to go on a once-in-a-lifetime trip, then the book may not be accurate compared to what's in the computer. And we had departments, like the Department of Anesthesia or Surgery or Medicine, using their own individual systems, and then it was translated to paper versus using an automated process to make those connections. So no dynamic updates and a lot of different sources of truth. So for us, this meant multiple FTEs working on keeping the departmental call schedule and the hospital call schedule in harmony, and a lot of rework. So that was a significant issue for us. So what was our plan moving forward to fix this? The first was we had some goals that we talked about from the beginning. The first was we wanted communication directly in the clinical workflow, not going to separate applications, looking for different apps, paper books, things of that nature. We wanted to make it simple, seamless, and easy so that it fades into the background for usability and we could just focus on providing the best care to the patient. And we wanted it automatically updated so that as changes were made, that information's coming across instantly. So how'd we do it? We put in an enterprise hospital call system that automatically pulls from the department call schedules to the enterprise level. We link that directly into our EHR, and that puts the call schedule right where we need it. And basically, we're respecting the workflow. And that's something that's really important to us as informaticists is we want the workflow to be seamless and easy and smooth so that clinicians aren't having to do a lot of training and work. It just makes sense, it flows, and it's easy. Finally, we wanted to use our EHR-based communication tools, and I'll get to more about why we did that, but it allows us to use our existing apps, and it allows us to link to the patient, which is really critical from a safety perspective and why we do that. So let's talk about our enterprise call schedule. We use QGenda as our vendor for that. It allows us real-time access to who's on call. And again, it takes that feed from the department system, which in many cases is the same vendor, and then that directly to the enterprise system. So updates are seamless, automatic, and everything is in real time. This really reduced that rework for staff. Talk about that a little bit more. And when there's an emergency, we've talked about the need to get a hold of somebody fast. Well, we're all carrying cell phones these days. And when we talk to our providers and at other organizations, they want that call when it's critical. Patient care and safety is first and foremost in our minds. So what this does is make sure that that cell phone number is available to the team when it's an emergency and they need to have that critical conversation. Now, our hope over time, and we'll talk a little bit more about this at the end, is that we move away from the cell phone number and move to something integrated into the app for voice communication, but we're not there yet across the board. So right now, cell phone numbers are what we have, so that's what we need to leverage. So our enterprise call schedule, this is an example here. And this is what it looks like on a monitor, and you can see all the different service lines that we have are represented, both at our hospital in Denver, as well as our Colorado Springs location, which has a significant number of inpatients. And as you click on these, you start to get some information. This is neurology's call schedule, and what you can see here is all the different roles. This is a very complex quaternary care environment, where they are, their physical location, what their type of role is. Are they an attending physician, a fellow? We have a robust training program, one of the top pediatric departments in the nation. So we have many trainees coming through here learning to provide care. So they are a critical part of our care team and are represented, and these are our advanced practice providers. And then we have their names. I've blanked out some of the details, their phone numbers, and some guidance as to how you would choose which person is the correct one to call. So you can see here, general inpatient floor team lead, neuro ICU team lead. These are first calls for issues in the floor or the ICU. And this really helps us to route the person on the first shot to who they need to get the answer to the question that they need. So really nice to have that guidance there. Now we fed that information to the EHR, and we use Epic for our EHR. And you can see here, this is our button to get to the on-call schedule, and it is the same for every single user. This is what they'll see across the top, and on-call will be there, so it's consistent and easily accessible. And when they click on it, for instance, anesthesiology, my specialty, this is what they'll see. And you have these cards that basically say first contact, pre-op, liver, cardiac attending. The enterprise schedule feeds into this. On-call is where we work and makes it immediately accessible. Now, our first contact can be in the operating room active, so we actually have it here that we want to be called for most issues. But if you're a pre-op attending, cardiac or liver, texting or chatting is the more appropriate option. So we're still in some cases where synchronous communication makes sense versus asynchronous communication. We're one of the first in the nation to make this integration and work closely. And again, thank our partners for allowing us to do that in industry. All of our clinical team members have access to this. Here's what, again, it looks like for neurology, a little bit more complicated. And do you remember those notes that came through where we said first contact, second contact? Here they are. So the notes actually come through first contact, general inpatient, first contact ICU. So the department puts this information in, it flows to the enterprise schedule, and then flows into Epic where it's available, our EHR. And what's also neat here is that you can flip through all the services and you can look at future dates to see who's on when in our EHR. So our action plan for messaging was we wanted some critical things to come together. Attach the patient when it's appropriate, set it up so that we could forward messages when we need to, be able to indicate when you're available and maybe when you're on vacation, and to respect that personal time and really vary the alert based on the criticality of the message. So if you think back to that matrix that we talked about, it had normal, important, and urgent across the top. So we can vary the alert that the provider receives or the team member based on that. Now, a funny story about this, when we rolled this out, I had many docs coming up to me saying, "You're never going to wake me up with my cell phone. It's not going to happen. My pager's the only thing that can wake me up." So we worked with our EHR partners and chose a fairly obnoxious alert for urgent messages, pushed that out across the system level, and defaulted the volume to 100%. We went live, and somebody came up to me in the hall the next day and said, "I'm sorry, I told you that you wouldn't be able to wake me up." Well, not only did you wake me up, you woke up my whole family. So we need to come up with a better plan. So at that point, we let the user pick the alert and set the volume down to 90%. Some of the alerts are shorter and more quiet. So this lets our users decide what's the right alert for you. Some people are light sleepers and some people are deep sleepers. But rest assured, everybody gets woken up if they need to be based on what alert that they pick. So let's put this all together and how it all plays. So we have a team that needs help in the ICU with an urgent situation, and they're trying to get a hold of an anesthesiologist, and they're going to intubate this patient in the next 30 minutes. They would go send an urgent message to one of the anesthesia team, select on-call, attach the patient, and then send it urgent. So let's say I got that message and I was in a backup role to help with the ICU. I could immediately click on that patient's name and start reading about that patient as I'm moving to the bedside and understand why I was needed at the bedside. Maybe they have a really difficult airway, or maybe they have many medical conditions, and I show up as an informed provider ready to go and to help because I immediately know who this patient is. And also, they were attached directly, not by translating a medical record number and a name across different devices. So from a safety standpoint, there's a higher likelihood that I've got the right patient that I'm looking at here versus if I have to get it on my pager, find a computer, copy the MRN over into the EHR, select that patient, and then start reading. So this simplifies that workflow, another principle from informatics that we're really striving for. So how did we get here from a training perspective? Because this was a major change for us. The first is we did mandatory computer-based training. Now, mandatory training doesn't always go over so well in many organizations with providers, but if you make the training impactful, and we have an excellent training team that we use to do this. We used videos to do this, even engaged our production team. So people in the videos were showing directly how we were using the system and explaining why, even add a little bit of humor to it. And that really got people engaged. We used all of our hospital communication channels, team leader conferences, huddles, other things to make sure that people knew, and then continue to provide ongoing feedback and support through our newsletters and other ways that we communicate with users. It hasn't been perfect, and I'll get into some of the issues we found in a little bit, but it's really important if you make a change like this to really focus on the training and make sure everybody's comfortable, because communication at the end of the day is life safety. Again, going back to the first couple things we talked about, when communication doesn't work, there's a risk that patients can get harmed. So we have to get it right every time. This is an example of something we had to address. So on one of our floors, we sent this out to kind of educate people that secure chat is not Snapchat. So what we noticed was a increase in messages over what was coming across in pagers, because our chat functionality feels a lot like a Snapchat or a Facebook message, iMessage, some of those different tools that we're all familiar with. So instead of one succinct message, we're starting to see more messages come through, a little more informal, kind of falling into how we chat with each other personally and in society, versus this needs to be a professional communication platform. So that's where that phrase comes from that we sent out in our training, and also some background on communication and why structured communication tools can be very important. And that's something we see that we're working through on an ongoing basis. You know, chat in EHR feels a lot like chat on your phone. So I've noticed myself doing it sometimes, where you might send somebody 3 messages, where if you'd stopped, paused for 5 seconds, collected your thoughts, you could send 1 message. So that's critical to think about. Resiliency in healthcare right now is a major issue. Coming through the pandemic, it's really been very stressful on all of our providers, but it was there before, even the pandemic, that we're all struggling a little bit with that communication overload that we talked about, and a number of other issues in healthcare that really affect resiliency. So we knew when we were changing the communication program, it would be really critical to partner with our resiliency colleagues. The good news is, at this institution, we have a resiliency committee. Dr. Jenny Reese helps lead that work, and really had a place that we could go to talk through these issues. And we put together a campaign of 10 different messages. I've highlighted 4 in this presentation that really helped us describe what was critical in ways to help everybody work together on this. And these messages were created not only with the Resiliency Committee, but again, in partnership between our provider informaticists, our nursing informaticists, our clinical leaders, our CMOs, and really coming together and making sure that we were all on the same page. So the first was keep it brief, no thanks required. And really, this is critical. When you look in your EHRs or other messaging applications or in baskets, you're going to find a lot of thank yous in here. And it's nice to be thanked, but it's another message. It comes through, it could potentially interrupt you. Many of the EHR vendors out there are working on ways to minimize the number of thank yous that come through, but it fills up your in basket. And while it feels good on occasion, it's another message that you have to triage and work through. So thanks is assumed at our organization, and we're working towards that goal. The next one goes back to something we talked about earlier in the presentation, which is consolidate the communication channels. We need to get away from using email for clinical matters, use in-basket, use our EHR email and keep it all in one place. Avoid personal texting, use the EHR function to do that, and keep those in-basket messages there and use the work phone numbers whenever possible. So that was really a critical element for us. Skip the email. Email is more vulnerable to hacking and being breached than EHR platforms. So it's important to do that. And respect the group. For those on the call that maybe started their professional lives back when email just started, I had just started college at the time where that got significant. And everybody probably remembers getting an email to 100 people and then 99 people saying, get me off this list because somebody accidentally replied to all. This can be the same thing. So we want people to send messages to individuals whenever possible and really limit group messages to when times where everybody on the group needs the information. Better to send it to one person and realize maybe this isn't the right person than to send it to 10 people and hope that you got the right person. So really a critical difference there to be able to do that. And these 4 things have really helped us. We're not perfect. We still see group messages and we still see plenty of thank yous floating around, but we're really trying to consolidate and streamline our communication, because the less communication that comes through and the more impactful that communication is, promotes resiliency and reduces burnout. And that's why we think that's so critical to work through that. So I want to talk about, based on some of what we learned a little bit, just from my perspective, what's an ideal communication strategy and how does that come together? And the first is, and foremost, is not only one device, but one application for voice, messaging, and clinical care, and bringing that all together. And you could add scheduling to the list and the thought that it needs to flow into that same platform so that we can see everything in one easy to access place that we're used to using. The next one to think about here is integrated, accurate enterprise call schedules. So communication doesn't work if you can't find the right person to communicate with. So knowing who is in what role is absolutely critical and foundational to the success of this, because without that, you can't figure out the right person, you can't get started. So having that information accurate, up to date, and at your fingertips was absolutely critical. And that's why we started on the call schedule part and then moved towards more innovative and modern communication methods. So think of that from you're building a house, starting with who's the right person to call, how do we get a hold of them, and then moving up the chain to the different communication methods and making sure. But if you're texting somebody that's on vacation, that's not going to do us a lot of good if they don't answer. That's delaying patient care. So really critical there. The next one that's critical is making sure that that message gets tied to the patient, make that seamless and easy. Here's an entertaining example. We want to make sure that we have the right patient listed and it's really straightforward to get into that patient's application quickly and easily. And that's what we can do here by just clicking right on the patient's name and boom, we're into the patient and we can start reading about them and we're all on the same page as to which patient we're caring for. And you'd think that'd be straightforward, but if you have a team caring for 20 patients and you're contacting a consultant that has a different selection of 20 different patients that they're covering, it can be difficult sometimes to make sure you are all talking about the same person. So we want our tools to reinforce that. Dynamic availability. This one is huge. So when people are on vacation, this goes back to a resiliency standpoint, we want to make absolutely sure that that time away is respected, because that's how we can regroup, reinvigorate ourselves, and come back ready to go and safely care for as many patients as we can. So we've really got to respect that personal time for relaxation and regrouping so that you're ready to go. So you can see here, we've got somebody that's unavailable. It's me, I'm on vacation, and it's important that that's respected. Now, one of the things that we're working with our EHR partners with, and also with our scheduling partners, is to make that dynamic. So ideally, when you're on vacation, that information would flow from the scheduling system to the EHR, and I wouldn't have to do anything. The system would automatically note that this person's not here and they're not the right person to contact. So you know how all of us are pretty used to out-of-office messages on email? Imagine having to do that on 5 different platforms. That's where we are now. You want to go on vacation and get it right? Put that into all sorts of different applications so that people know you're on vacation. Versus, can we do this for the clinicians automatically? That's a big win when we get there. The ability to control alerts and breakthrough. So this is critical messages are critical. So when you have a phone, and maybe if you're like me and you've got a family with 3 little kids and they love to get a hold of Dada's phone and start playing with it and put it in silent mode, it's really important that the critical message makes it. So we leverage that. When you send an urgent message to somebody, it's going to break through silent modes, other modes, to make sure that that message makes it, even if somebody in your family might be working a little bit against you there in that format. So that's critical to get that right as well. And finally, respect for resiliency and burnout. This graph here is from the VA, and you can see here, these are all the drivers in the center. And you can see when these are less optimal, you get exhaustion, you become more cynical, ineffective. But when you've got all this working right, you've got that vigor and dedication to the work, and you can take on and care for as many patients as you can to really help as much as you can, and really have those meaningful interactions with people that drive great patient care. So many of these are affected by communication, control and flexibility, work-life integration, efficiency and resources, workload and jobs demands. Communication touches many of these. So if we can get it right, we can improve resilience and we can reduce burnout. And that's why doing this work is so critical. We're just on the front of it, and we have a lot to learn, partnering with many of you on this webinar today. So all I'm asking is that we all partner together, share what we've learned, and really move us away from this and more up towards resiliency and engagement. And finally, we want to make sure you're able to use a personal device and one device only. The days of, if you remember that picture earlier in the presentation, of having 4 or 5 things hanging off your scrubs, falling on the floor, is not a great plan. So if we can get it down to one device that we're familiar with, that we use day in and day out, that's really going to help us go through that and make sure it's easy and simple. And speaking of simple, that's really the key here. You know, we in the tech world, in informatics or IT, we have this vision that tech is easy. And for many people, it's not. Complex workflows across multiple applications is not easy and straightforward. So for many of our users out there that struggle with email, imagine now trying to struggle with 10 different communication platforms. We want to make sure that we get this simple, easy, seamless, integrated, so that it fades into the background and that providers can focus on caring for patients, care team members can focus on care, not on making the tech work. And that's really critical to success. So in closing in this presentation, I want to talk a little bit about some of our lessons learned. The first was, in terms of enterprise scheduling, that we were consistent across departments. So when we rolled this out, we had many different departments that were on different systems and utilizing different terms. And it was important to get some consistency across departments. That's a significant change management lift, because change is hard and everybody's used to their method in their department. Now, some of this you can translate, right? You can take their definition and change it as you move it across, or their title for that role, but some of it you can't. And what we also found was, is if somebody is changing things in their local schedule and they change the wrong fields, that means that it won't translate all the way to the EHR. So we had to do some training so that the local schedulers in the departments knew what they could change and what they should not change in order for it to come across. Now on the EHR-based chat side, we've been partnering with our EHR vendor, to help us in some of these issues. If you noticed, one of the things when we had first contact in neurology, it was near the bottom. We want to be able to order those cards in a way that's intuitive to our users and are working forward towards that. Pre and post call mean different things to different people, so those times aren't always accurate. I will say we found a attending physician with a flip phone, and we found one that didn't want to move forward with this, so he bought a BlackBerry so that he couldn't run these applications on his personal device. So change fatigue is real. Taking this seriously and acknowledging it up front is key. But fortunately, those are a few little anecdotal examples. Phone call versus messages. When is it appropriate to make that phone call, interrupt that person? When is it appropriate to use the message? We still are constantly refining that. People's definition of urgent can be different. Some people think that something's very urgent to them. Maybe they're signing out and they're going home. But to the other person, it might not be urgent, and they would prefer that that person passed it to the person taking over for them and dealt with it during daytime hours. So really, what is that definition of urgent? And then there's the whole controversy that's out there around bring your own device and who, or if anybody, compensates anybody for the use of that device. And that's something we're working through, and we've learned can have implications based on what state you're in and what the laws of that state are. But in general, as we go through all this, my personal thought on this is if we make it simple and we get it all on one device and it's on that provider's personal device that they use all the time, they're going to be very happy with that. And some of the other issues are going to fade into the background. If it's difficult and it requires multiple apps and flipping back and forth and it's not intuitive, then we really start to hear the feedback on why are you installing 4 different apps on my phone and why can't you make this simpler? So just a little bit about how this project was successful. I won't lie to you. I felt like that person in the middle between those 2 graphics at one point in this project, wondering if I was going to make it to the other side. But fortunately, we have an awesome team here that backed each other up. And really, what we were able to do is get a fully integrated call schedule. Again, that bedrock foundational element, so we knew who was on when. We eliminated almost all of our pagers. That saved us a couple $100,000. We now have messaging that meets all HIPAA requirements, safe and legal. I think this improved our communication strategy because some of the things we talked about, attaching the patient, putting those messages in the EHR, things of that nature really helped us. And we've been at this coming up on 2 years now, and we're working through a few things, but I think we are seeing some areas where we're positively impacting resiliency, but we're also seeing areas where we need to continue to focus on resiliency as we still move through the pandemic. Doing this in the middle of the pandemic was an interesting decision, but we felt like we just had to start moving forward. And really, one of the positives to that is the system was under a lot of stress from the beginning. So we found out really quickly what was working and what wasn't working. But overall, this project was a major success that kicked us off down the road to modernizing our communication. So with that, I know we have a lot of questions in the chat. I'll try to answer as many as I can. I thank you all for joining us today. And again, thank Becker's for hosting today.
Yeah, thank you, Dr. Guffey, for a great presentation. We're going to switch over to the Q&A session. So again, you can submit any questions you have by typing them into the Q&A box on your webinar console. And we're going to go and get started with the first question since we have so many flooding the chat. Dr. Guffey, first question I have for you, does Children's Hospital Colorado have additional locations or clinics using QGenda On Call and Epic Secure Chat outside of its main campus?
Yes, absolutely. We have this implemented across our entire system of care. So that's 2 major hospitals, 2 other facilities that have a inpatient bed presence and operating rooms, kind of a north, we call them a north and a south surgical center, and many clinics across the system.
And how was the experience and integration between Epic and your enterprise call schedule program? And also on that, how long did it take to roll it out with QGenda implementation?
Our total project timeline was a little under a year, and I'm fortunate to say our vendors worked very well with each other and us to be able to implement this.
Another audience question for you is, what's your workflow when the schedule changes? Do you make the change in QGenda or Epic?
Ideally, you're making the change closest to the work, right? As a expectation. So we're making the change in the local system, and then it's automatically propagated up because that's where our admins are. That's where you can just log in. So in many of these local scheduling systems, you enter your request for time off. You might make call schedule swaps. So people are very used to using that system locally. So what we do is make those changes there, and then they propagate up.
Gotcha. So another audience question for you, is there an escalation feature? So if the loop is open for too long, the system escalates the communication to another team member to respond?
So yes, but it's manual. And that goes back to that policy definition we talked about, why it's so important for the sender. Like in iMessage on an Apple product, you can see if the person has read your message. But unlike an Apple product, you can't turn that off. So when somebody sends a message, they can see when the recipient reads it. And ideally, that recipient would respond. And if you're not getting what you need to escalate that. Just like if you called the OR and said, I really need to speak with this surgeon about this patient. If that surgeon doesn't call you back, you're going to have to find another person or way to communicate. So the responsibility is on the sender to make sure that the recipient has received the message and you're getting what you need. The responsibility is on the recipient to be receptive to messages, available for messaging, and to keep everything up to date.
And I know you mentioned a lot about, different alerts and kind of the choice being put in the hands of the person getting those alerts. So how are you monitoring the appropriate use of various methods, especially the use of personal texting, PHI, et cetera?
Yeah, excellent question. It's hard in some cases to monitor somebody's personal device because it's their personal device. But what we've seen is a steady increase in EHR-based messages. So that leads me to the hypothesis that if I'm still seeing a continual increase, that we're decreasing in those other channels. So we monitor that very closely. As far as alerts, urgent alerts are automatically sent in a way that triggers critical notifications. And when you send an urgent message, it keeps going off every 3 minutes until that person answers it. When you send a routine or an important message, it goes off once, and we rely on the person seeing it. For urgent messages, we specified that is needing an answer within 30 minutes. For important, we have that at about 4 hours. You can think of it as half a shift. And for routine, it's effectively a day or a shift, depending on your clinical assignment. So that's how we decided that. And the way we decided that was by leveraging our Unified Communication Application Governance Committee. So here at this organization, we have 22 application governance committees that are multidisciplinary, covering every aspect of the EHR, where we typically have a director and managers from that area, informaticists, IT professionals, all coming together and making those decisions in a shared governance type model.
Another question for you, how does emergency team activation work at your system?
So a true emergency team activation is triggered by the buttons in the walls or calling a special phone number. And those currently are not coming through our EHR application. That said, there are sites out there that are partnering with EHR vendors to move that in there. And that is our plan. We have our voice communication and our emergency team activations on a historical vendor going to hospital phones, but those phones run our EHR's applications as well. So over the next year or two, we're going to be moving the emergency team alerts into our EHR-based applications as well. And then over time as well, as we partner with our EHR vendors, we'll move voice communication into that same application. And that'll be a big win, because that gets us to that goal of everything in one app, on one application, on one device. And that's just really, we think that's the right thing to do to really get provider acceptance.
And kind of on that note, is OnCall QGenda integrated with Tiger Connect, and is there a reason there's both Tiger Connect and Epic?
So we leverage that application for external communication. It's not integrated in that way.
Okay, great. Thank you for clarifying. Another audience member asked, what sort of leadership support did you have to get this project going?
One of my best partners in this work was Dr. David Brumbaugh. He was our associate CMO when he started, and then promoted to our system CMO, and his support is absolutely critical. We partnered together on this from the beginning, so that's a critical relationship. And then he helped remove a lot of barriers and get support from us there. Your IT professionals are absolutely critical in this. So our vice president of, or actually our associate CIO, Amy Feaster, our CIO, Dana Moore, their support was absolutely critical. My partners, Emily Reyes, our Chief Nursing Informatics Officer, was critical. My partner in the CMIO role, Gwen Kirby, was critical in this, really helping with a lot of the ambulatory type workflows here. So really, it's a number of us coming together to get this right across the system in a number of different roles. And then really, just broad-based support from your executive team, which then allows you to have a number of connections with all of the different directors around the organization and your medical staff. So, really, I think the best advice I'd give on this is it's important to go the extra mile and meet with as many different people as you can. Go to department meetings, talk about this there, leverage every standing group you have to get this out there as to why you're doing it. Because, pagers have been on people's hips for 30 years. So this is not an insignificant change. I mean, that's a career for somebody in healthcare. So really critical to get that right and to get your partnerships right and to not try to do this on your own. So that's how we did it.
So with those different department meetings, do you mean kind of butt into other meetings you weren't originally invited into? I'm just curious.
Yep. In some cases, we've made a play to get on the agenda, and join for 5-10 minutes and talk about it. I know our CNIO partnered very closely with our CNO, Pat Gibbons, to make sure that nursing was fully on board and prepared for these changes. So really just critical to work through both of those structures, your care teams and your provider side, and get to as many of those meetings as you can and talk about it. And, listen to the concerns. You may know that the concern is something you already solved for, but letting people communicate why they're uncomfortable is important. And then that enables you to know what you're up against so you can design your training materials to address those concerns. So that when people see the training, they feel very listened to. And when you're making major changes, just think back to those basic change management principles and go the extra mile. Because every little place that we didn't, we noticed. So if we missed a group or a meeting, that was the area where, like, boy, I wish we'd gone the extra mile to attend that meeting. I think that's good advice in general for informatics change, but it becomes really critical when you're changing a communication paradigm.
And on this note of executive support, how did you justify the ROI given the cost of scheduling, messaging, and other systems?
So there's the security implications, right? So that's a critical thing to always consider. We saved money in this project because we were able to eliminate pagers. So we eliminated a device, the support for that device. So net cost savings was a savings. And we were actually able to redeploy a couple FTEs that were working more closely and trying to keep those call schedules straight. So they're now able to focus on other work in the organization and our kind of our incoming call center for referring patients in. So that helped us there too. So really some significant cost savings and staffing changes. There's savings as part of this. So that's always going to make a CFO happy.
Right. Dr. Guffey, can you speak to the adoption and change management? Attendee said, it seems like the technical build and the list is manageable, but change management is critical.
Yeah, I think that's a fair statement. The vendors we partner with made the, in our internal team being very sharp, made the change, the technical side of it, while we certainly had some challenges, you're right, that was very manageable. We, from the beginning, knew that communication is one of those really critical issues. So we really focused on communicating with as many people as we could to get that change management right. And like I said, our CMO and our CNO also intrinsically understood what a major change this was. So we had all the partnership we needed to really do that. So you want to make sure that your medical and nursing leadership and your IT leadership are in complete alignment with you as you move through that process. And here, we enjoy excellent relationships across the board with those teams. So it was really straightforward to get the support for that change management. But you're definitely going to run into people that this is not their cup of tea and they are not interested in this change. So like with any technology adoption, you're going to have people that were already leveraging your EHR chat extensively. And you're going to have people that are putting messages up saying, I don't chat, just call me. And you have to just a little bit of patience, conversations, and manage that. But this is not a small undertaking.
Gotcha. And we have time maybe for 2 more questions. So I'm going to sneak these in real quick. Have you had to solve for a more rural area in which cell connection is not consistent or reliable?
Yeah, so what's nice about the EHR-based messaging applications is they can leverage both the cellular band and Wi-Fi for communication. So that's really helped a lot. For those that are familiar with Colorado, driving up towards the mountains into some of those areas west of Denver, you can definitely have some communication drops, but they're short. And once you reconnect to the network, that message is coming through. And remember, if it's really critical, you should be using voice. And if it's the person you're calling, if it's really a critical issue, is probably very local. So that's a really good point you bring up. Any communication system has to have an element of redundancy to it, right? If somebody doesn't answer their phone or doesn't answer their pager because the battery died, we've been dealing with this in healthcare for a long time. So we're well equipped to address that. So it's definitely something to be concerned about, but we've not found our electronic systems to be any less reliable. In fact, I think they're more reliable than the methods that we were using previously, in my opinion. And there's one question I want to address just briefly. I know as an anesthesiologist, people are going to be concerned with the OR environment. We're working really closely with our EHR vendors. There's some things we can do there. So urgent messages are going to our circulating nurses, routine messages are waiting until the end of the case, and phone calls come through and are transferred into our operating rooms. So we feel like we're in a pretty good place in our OR workflows.
So just to kind of run us out, what would you like to see next in regards to optimizing the on-call communications workflow? Or where do you feel like more collaboration could be made between these enterprise systems?
It's that individual day-to-day status. So start with vacation. If somebody is on vacation, that should flow seamlessly all the way through, and they should not have to put a vacation message on. But move that even further. The local system will say, this person's in clinic, this person's in the OR, like what are they actually, or they're on a research day. If we could propagate that information all the way through, then I know if I'm sending the message, what is that person doing that I'm sending it to? And are they the appropriate person for me to send the message to? So there's a lot of information in that enterprise call system. How do we use that information in our EHRs in an automated, reliable way to relieve the clinician of having to do some of that manual work. I think that's really the future there.
Great. That's all the time we have for today. I want to thank Dr. Gussey for an excellent presentation and QGenda for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. If we didn't get to your question, no worries. We will after the webinar. Thank you again for joining us today. We hope you all have a wonderful afternoon.
Thank you.